All right, so guys and gals, welcome back, and we're going to end our review with talking about hemostasis. So I always like to start with a big picture of what are we exactly trying to do. So here we're clotting some blood, and why are we clotting some blood? Because we have damage. So damage to a blood vessel by damaging the endothelial, which is what's lining the blood vessel. So we need to fix what's damaged. And how do we fix what's damaged? The first thing that we fix is putting a stop to the bleeding, and stopping the stop to the damage. So how do we do that is we platelets come in first, and then after that coagulation factors come in and they bind to the platelets, and they form like a small thrombus that kind of uh, covers the damaged part. So the first thing that comes in is platelets, and platelets are responsible for primary hemostasis, and then coagulation factors and fibrin clots are responsible for secondary hemostasis. If you look to the right, this is a picture that I took from uh, Pathoma that talks about the factors. So, and I really like how Dr. Satar kind of puts it. So, factors, there's two pathways: the intrinsic pathway and the extrinsic pathway. The intrinsic pathway starts with factors 12, 11. You skip 10, and then 9 and 8. And then the intrinsic factor starts with factor 7, and then they meet here with factor 10, and then 5, 2, and 1. And 1 is the fibrin clot that's kind of binds the platelet and makes this thrombus. So with that in mind, let's talk about hemostasis, and this is a really um, a confusing part that confuses a lot of students. When do we use what? When do we use antiplatelets versus when do we use anticoagulants? And what's the indications? And how I like to think about hemostasis, or if there is any bleeding or if there's any clots and how to stop it, is to think of the circuits. And how I think of the circuit is to think of high pressure circuits and low pressure circuits. And what do I mean by high pressure circuits? High pressure circuits is circuits that have high pressure in them. So whether it's the aorta, whether it's the coronary arteries, whether it's the cerebral arteries, whether it's the peripheral arteries, and all of these arteries have high pressure in them. And the disorders that are caused in high pressure circuits is ischemic stroke, so in the cerebral vessels, the early phase of myocardial infarction, and peripheral vascular disease. So this is what I mean by high pressure circuits. Now, let's talk about the other sides, low pressure circuits. So what are low pressure circuits? So low pressure circuits are um, circuits that have low pressure in them. So for example, your veins of the leg, these have low pressure. Your pulmonary artery that has low pressure. Your left atrium that has low pressure. Your veins in the head, so the dural veins and the dural sinuses. So these have low pressure. So if you understand that difference, then it make your life much easier. So for high pressure circuits, the main clotting player is platelets. And how I think of it is, these circuits have very high pressure. So the first thing that you want to do is to put in that platelet plug. And what you use for these disorders is you use antiplatelets. So for example, aspirin. So understanding that part is that high pressure circuits like stroke, myocardial infarction, peripheral vascular disease, main clotting player is platelets, and use antiplatelets if you have any of these disorders. Now, if you have a low pressure circuit like a DVT, uh, a deep venous thrombosis, like a thrombus in your veins of the leg, whether if you have pulmonary embolism, an embolism in your pulmonary artery, if you have atrial fibrillation that's causing a clot in your like left atrium, for example. That's a low pressure circuit. Dural sinus thrombosis. So this is a thrombus in your dural sinuses. That's a low pressure circuit. Or even late phase myocardial infarction, because remember that the first phase is to get platelets, but the second phase is to get fibrin clots. So even in late phase myocardial infarction, that can be kind of low pressure because you've sort of stabilized that bleed. So the main player for low pressure circuits like DVT, PE, AFib, late MI or dural sinus thrombosis is coagulation factors. So very, very important to understand. High pressure circuits, strokes, MIs, early MIs, platelets, DVT, PE, AFib is fibrin clots. And then what you use for these is use anticoagulants like heparin or warfarin. I hope that makes sense to you. If it doesn't, please go back and try to understand it, or shoot me an email and I can explain it to you in more details. Now, we'll talk first about anticoagulants. So what we're trying to accomplish here is that we're trying to prevent formation of a fibrin clot. And how do we make fibrin clot is we make it through that common pathway that we talked about. Number one is a fibrin clot. So how do we prevent formation of fibrin clot? So the first thing that we can do is that we can inhibit some of the factors. So factor 10, 9, 7, 2, or protein CNS, and that's through warfarin. We can inhibit factor 2 and factor 10 by activating antithrombin, and that decreases the action of thrombin, and that's through the medication heparin. We can inhibit factor 10. That's the first factor in the common pathway, and these are through oral agents like apixaban or rivaroxaban. These are factor 10 inhibitors, or some parenteral medications, IV or subcutaneous, like enoxaparin or fondaparinux. These are also factor 10 inhibitors. We can inhibit it later in the pathway. We can inhibit thrombin, which is factor 2, like using medications like bivalirudin, argatroban, or dabigatran. And these are what we call direct thrombin inhibitors. So that's how we prevent formation of a fibrin clot. Now, let's say we do already have a fibrin clot and we want to break it down. How do we break it? How do we break down a fibrin clot? So the body has a mechanism for breaking down fibrin clots using an enzyme called plasmin. So we have medications that activate plasmin, and plasmin breaks down the fibrin clot. And these medications are namely alteplase and streptokinase. So understanding that big picture, we can delve into depth of these medications. So the first medication that we're going to talk about, and one of the highest yield medication that you'll see in your block exam, in your shelf exam, in your step, and in your practice, is warfarin. So warfarin is a really important medication. How it works is that it inhibits carboxylation of vitamin K dependent factors. So there are a bunch of factors, namely 10, 9, 7, 2, and protein CNS, and these need vitamin K to get carboxylated and to get activated. And how I remember it is 1972, that warfarin prevents 1972 CS. These are the factors that it inhibits it. It affects mainly the extrinsic pathway because of factor 7, and it prolongs the prothrombin time. So one thing that I didn't mention is that here, this side, the extrinsic pathway, you monitor it using prothrombin time, and the intrinsic factor you monitor it using partial thromboplastin time, so PTT. So here PT, here PTT. This side is affected by warfarin, and you monitor it using PT. This side is affected by heparin, and you monitor it using PTT. Not that warfarin does not affect PTT, it does, but to the most extent it affects PT or INR. What is warfarin used for? Is it used for a high pressure circuit or a low pressure circuit? Yes, it's used for a low pressure circuit, mainly DVTs or PEs, and it's also used for anticoagulation in AFib. And I guess let me take a step back and tell you why is AFib need anticoagulation. And the reason for that is if you have the atria kind of like fibrillating and not really moving, the blood is going to kind of stay there and it's going to clot. If it clots, then if there is any return to normal sinus rhythm, that clot is going to go to the left ventricle. And if it goes to the left ventricle, it's going to travel anywhere to the brain. It causes a stroke, to like the arteries causes mesenteric ischemia, or to dislodges to to anywhere. So that's why we need to anticoagulate patients with atrial fibrillation. So we use warfarin for that, or any of the other anticoagulants. Notes on warfarin is that there's pharmacogenomics differences in metabolism. What do I mean by that? What that means is that there's differences from person to person based on genetics and how they metabolize the medication. And that's one of the most studied medication in pharmacogenomics. It is metabolized via CYP enzymes, so the liver enzymes, and it has a prolonged half-life. So it takes about 4 to 5 days to work, and the reason for that is the factors that it inhibits has a prolonged half-life. So it takes time for these factors to uh, kind of disappear, and you get the anticoagulation effect. Warfarin is one of the most famous medications for causing drug-drug interactions, and there's medications that will increase the INR, and there's medications that will decrease the INR. I didn't want to go into too much depth about these medications because you will come across them and you'll eventually like have to memorize it, or you'll have to look it up. But understanding the concept that warfarin causes a lot of, or is involved in a lot of drug interactions. The last thing that I wanted to talk about in the notes for warfarin is that if your patient is going to eat greens that are containing vitamin K, you want them to have a stable amount of greens. And the reason for that is, again, greens have vitamin K, and vitamin K antagonizes warfarin. So you want to tell them, hey, if you're going to eat a salad every day, but let me know so that I can adjust your warfarin dose. Side effects for warfarin is very important. Biggest side effect, of course, it's bleeding. Second side effect is that it's teratogenic, so it crosses the placenta and it causes deformities to the fetus. The third side effect is that it causes warfarin-induced tissue necrosis. And let me take a minute on explaining what that means. So, as we have agreed earlier, is that warfarin inhibits protein CNS in addition to proteins to factors 1972, so 10, 9, 7, and 2. The problem comes is that protein CNS have shorter half-life. Sorry, I meant to put shorter here. Have shorter half-life than factors 10, 9, 7, and 2. And that comes into play because protein CNS have anticoagulant properties. So factors 10, 9, 7, and 2 have procoagulant properties, so the blood clots. Protein CNS have anticoagulant properties, so the blood doesn't clot. So if you inhibit protein CNS first, what does that leave you with? Which factors are going to be left? 10, 9, 7, and 2. So you're going to end up being hypercoagulable. And if you become hypercoagulable, you end up with these microthrombi and you get skin necrosis. So very, very, very important side effect to understand from warfarin, and it's also important to understand the mechanism behind it. How do we treat this? We give them another anticoagulant that will inhibit all of them at the same time. So we give them, for example, a medication called heparin, and this is termed bridging. So we're bridging with heparin until the effect of warfarin have started and that all of the factors have been inhibited. Um, and that's mainly to inhibit, factors 10 and 2 with the heparin. If you have bleeding from warfarin, what are you going to do? First, you're going to monitor the INR. So you're going to check the INR and see if it's high or low. If it's a critical bleeding, let's say it's a brain bleed and you want to reverse it quickly, you can use a prothrombin concentrate. So that has factors 2, 9, and 10, and this is very quick and it has a low volume, like 5 mLs or anything like that, or something like that. The second thing that you can do is that you can give them fresh frozen plasma. So fresh frozen plasma has coagulation factors, mainly the vitamin K factors, which is 10, 9, 7, and 2, and it has factor 5, and that is also quick, but is a lot of volume to the patient. And then lastly, if you have some time and you don't need to reverse the warfarin acutely, you can give them vitamin K. Um, and just one last thing that I will talk about warfarin. The brand name for warfarin, and I didn't put it here, is called Coumadin. And you'll hear that a lot in clinical practice that patients are taking Coumadin. Next agent after warfarin is heparin. And heparin is a naturally occurring substance in your, or protein in your body. The mechanism of the synthetic heparin is that it activates antithrombin. So antithrombin binds to thrombin and lowers the activity of it. And thrombin is factor 2. It also goes after factor 10. So heparin goes after factor 10 and factor 2. So it affects the intrinsic pathway, and monitoring is using the PTT. Heparin has a very short half-life, and it's used as an IV medication. Now, what is it used for? Is it used for high pressure circuits or low pressure circuits? Yes, it's low pressure circuits and mainly DVT PE or anticoagulation for AFib. Now, heparin is also used for acute coronary syndrome. And can you tell me whether it works, kind of like in the early phase or the late phase of acute coronary syndrome, which is MI? It's the late phase, because first, if you're having an MI, the platelets are going to rush in, and then after that, the factors are going to come in. And in MI, we want to do everything that we can to decrease the propagation of these thrombus. So we can use heparin in a myocardial infarction or acute coronary syndrome. Side effects for heparin is, of course, bleeding. You can get this side effect called heparin-induced thrombocytopenia. And what happens is that heparin is kind of like a big molecule, so the body reacts to it and it forms IgG antibodies, but instead of attacking heparin, they attack heparin-bound platelet factors. So heparin kind of binds in the platelets, and the immune system comes, or the antibodies comes and attacks those platelets. So that's why it's heparin-induced thrombocytopenia. The problem is not just thrombocytopenia, but you also get thrombosis, because these platelets kind of clog into the vessels, so you get a thrombotic state. If you have bleeding from heparin, you can reverse it using a medication called protamine, and protamine binds to heparin. So we talked about warfarin, inhibiting factor 10, 9, 7, and 2 in CNS. We talked about heparin, inhibiting factor 10 and 2. Now, what we can also inhibit is we can inhibit factor 10 using factor 10 inhibitors. So there's two routes or two kind of subclasses of factor 10A inhibitors. So the parenteral routes, which means parenteral means IV or IM or sub-Q. Is enoxaparin or fondaparinux. So these inhibit factor 10A. They have a longer half-life than unfractionated heparin, and they're used for also low pressure circuits, DVT, PE, or AFib. Their side effects is, of course, bleeding. They has less incidence of heparin-induced thrombocytopenia. By the way, these are enoxaparin is called low molecular weight heparin. This is just a side fact to know. Fondaparinux is sometimes used in patients with allergy, the heparin-induced thrombocytopenia, and there is actually no reversal for these agents. The oral agents is apixaban and rivaroxaban, and these are new agents that came on the market recently in the last few years. They inhibit factor 10A. You do not need to monitor these agents. So these have sort of replaced Coumadin or warfarin for the treatment of AFib or chronic DVT or PE. The problem is that not easily reversible if you get a bleed from these medications. Next is are thrombin inhibitors. So thrombin is factor 2. So this is laid down in the coagulation cascade. So these medications are called bivalirudin, argatroban, or dabigatran, and they directly inhibit the activity of the free and clotted thrombin. They have sort of uh, different uses. So dabigatran is mainly used for DVT or AFib. Argatroban is mainly used for patients that develop heparin-induced thrombocytopenia and you need to anticoagulate them. And then lastly, bivalirudin is used for patients that are going percutaneous coronary stenting. So the patients that are going to the cath lab, you give them bivalirudin and the role is to prevent stent thrombosis. These medications are very high risk for bleeding. The only medication that has a reversal agent is dabigatran, and you reverse it with this drug is adarucizumab, not very high yield. But the biggest thing that I would take out of this is that these medications are direct thrombin inhibitors. Lastly, in the anticoagulation, so we're trying to prevent the clot from it being formed. Now, what happens if there's a clot that has already formed and we need to lyse it? How are we going to lyse it? So we can lyse it using fibrinolytics, so mainly alteplase and streptokinase. So alteplase is actually a naturally occurring enzyme. So it converts plasminogen to plasmin, and plasmin cleaves thrombin and fibrin clots. So this is naturally occurring in our bodies, but we have made use of this to break clots. Indications for fibrinolytics: if you have a myocardial infarction that is acute and you don't have a cath lab available, you can give a fibrinolytic to break that clot. For early ischemic stroke, if you have a patient with a stroke and you need to break that stroke if it's a thrombotic stroke, you can give fibrinolytics. And finally, if you have a large pulmonary embolism, large saddle pulmonary embolism, and saddle means that it's occluding the main pulmonary stem and then the two branches of the pulmonary arteries that in a way that affects hemodynamics. You can also give fibrinolytics. Side effects, of course, it's severe bleeding and you reverse it with anti-fibrinolytics. Which brings us to our next uh, class, which is the antifibrinolytics or the inhibitors of fibrinolysis. So these are aminocaproic acid and tranexamic acid, and they pretty much antagonize the fibrinolytics. So they inhibit plasminogen activation. If you inhibit plasminogen activation, then you can't break the clot that you've made, and you're gonna have a clot. So they're used for bleeding. They're used for bleeding from fibrinolytics or bleeding from surgery. If you have cardiac surgery or traumatic surgery, you can use these medications. Side effects, of course, is thrombosis. So what we have talked about so far is anticoagulants. These are medications that block the factors, and they are used in mainly low pressure circuits, so DVT, PE, AFib, late myocardial infarction. Our next class of or big category of agents is the antiplatelets. So again, the antiplatelets are used in high pressure circuits, so like early myocardial infarction or ischemic stroke, uh, that you have platelets as the main player. And to understand antiplatelets, we have to understand how platelets work. And to understand that, we have to understand also the receptors on platelets. So there's two big receptors on the platelets, mainly GP2B3A and GP1B. 2B3A binds platelets together using fibrinogen. So if you have like two platelets, one platelet here, one platelet here, you have in the middle GP2B3A receptor and then fibrinogen in the middle. And then the second receptor is GP1B, and that binds the endothelial surface with the platelets. So the platelets kind of stick on the endothelial surface using von Willebrand factor. Now, for these platelets to clot, they have to aggregate together. Now, how do they aggregate together? So the first thing that helps them aggregate is thromboxane A2, which is um, a molecule that's secreted by the platelets in response to the COX enzyme. So first thing that we can do is that we can inhibit thromboxane A2 synthesis using aspirin. Second thing that we can do to inhibit platelet aggregation is that we can decrease cyclic EMP expression. If you have a lot of cyclic EMP, then you have a lot of platelet aggregation. And the medications that decrease the cyclic EMP expression is these two medications, cilostazol and dipyridamole. Third way that we can inhibit platelet aggregation is that we can inhibit exposure of these receptors, the 2B3A receptors, and these are using medications clopidogrel, prasugrel, and ticlopidine. And lastly, if we haven't been able to do any of this, we can directly inhibit the receptors using medications epsiximab or eptifibatide. So that's the big picture of antiplatelets. Now, going into the details. First, a medication that we're going to talk about is aspirin, and we've already talked about aspirin in details earlier, but I'm going to talk about the antiplatelet effect. So it's irreversibly inhibit COX-1 enzyme, so it inhibits the synthesis of thromboxane A2, thus inhibiting platelet aggregation. The inhibition actually lasts for the whole half-life of the platelets, so around 5 to 7 days. So what is it used for? Is it used for high-pressure circuits or low-pressure circuits? First, it's an antiplatelet, so high-pressure circuits. So myocardial infarction, you can use it for primary prevention, so patients that have not had a heart attack. You can use it for an acute heart attack, or you can use it for ischemic stroke or TIA prevention and treatment. Side effects, we've discussed it previously, but the main thing is bleeding. The second agents is our ADP inhibitors. So these are the clopidogrel, prasugrel, and ticagrelor. And how they work is that there is this receptor in the platelets, it's called ADP, and there is a subtype for it called P2Y2. So these medications come and they inhibit this ADP receptor. And why ADP receptor is important is because it's responsible for the expression of the receptors that are 2B3A. And do you guys remember what 2B3A receptors do? Yes, they bind the fibrin clot to the platelets and makes a stable clot. These medications are used for myocardial infarction. They're also used to decrease the thrombosis of coronary stents. So a patient that had a coronary stent, you can give them these medications so that the stent doesn't thrombose and clot. And it's also used for recurrent ischemic thrombotic stroke. Side effects for it, of course, is bleeding. Now the last agents are direct 2B3A inhibitors. So these are epsiximab and eptifibatide. Again, they're direct inhibitors of the 2B3A unactivated platelets, preventing aggregation. So when you really want to use these is for the fast onset for platelet inhibition. So if a patient is having percutaneous coronary angioplasty and you want to inhibit platelets acutely, you can give these medications. Only in patients that are going to the cath lab that are getting an angioplasty or getting a stent placed. Side effects is they cause thrombocytopenia because they inhibit these receptors on the platelets. Last agents that we're going to talk about is the cyclic EMP inhibitors. So these are cilostazol and dipyridamole. They're phosphodiesterase inhibitors. They inhibit the breakdown of cyclic EMP, and they lead to a decrease in platelet aggregation. The biggest use for this is in peripheral vascular disease, mainly cilostazol, and they're also used for prevention of stroke or TIA, mainly dipyridamole and aspirin. Side effects is bleeding, and you get facial flushing and hypotension because you're inhibiting phosphodiesterase enzyme. Now, this is sort of an overview of anticoagulation and antiplatelets. What I wanted to do is to take a moment to review treatment of some of the common disease states since they're also scattered. And I wanted to kind of bring it all together since this is really the important part that you'll be tested on in your shelf or in your step. Mainly not too much in your block exam, but in your step one. So the first thing that I wanted to talk about is treatment of myocardial infarction. So in the acute phase of myocardial infarction, the initial treatment that you want to do is using an acronym called MONA. So MONA stands for morphine, oxygen, nitro, and aspirin. So the first thing that you want to do when a patient is coming to you with a heart attack, you want to give them some morphine. First thing, it helps with the pain, but it's also a vasodilator. It dilates some of the arteries. Oxygen, you also give it to them, and it's a vasodilator. Nitroglycerin, you can give it to them to decrease the myocardial demand, as we have talked about earlier, and then you give them aspirin to decrease further thrombus propagation. So these are the first thing that you want to give them. What you can also give them is you can give them heparin or enoxaparin to also prevent further thrombus propagation. So aspirin early on prevents platelet, heparin and enoxaparin prevents fibrin clots, and that's to prevent more thrombus. So you've stabilized the patient. Now, what are you going to do about this occlusion in their coronary artery? So what you can do is you want to reperfuse this coronary artery. So the first line is you take them to the cath lab. So you give them a stent in their coronary artery. If you do not have a cath lab that is available, you give them alteplase, which is a fibrinolytic to break the clot. So this is the acute phase of the myocardial infarction. The subacute phase of the myocardial infarction, which is after the patient has been stabilized. And this is where your medications come in to decrease the likelihood um, of more heart attacks or more complications. So the first thing that you can give them is antiplatelets, aspirin and clopidogrel, to prevent stent occlusion. You also give them a beta blocker and an ACE inhibitor because they have been proven to have mortality benefit because of the reason that we've discussed previously. And you also give them a high intensity statin to decrease atherosclerosis. So this is sort of the big picture treatment for myocardial infarction. Now, next is I wanted to talk about the treatment of stroke. If you have a patient with an ischemic stroke, that means it's a stroke that's causing ischemia to the tissues around it. The acute phase is you can give them alteplase, so you can bust that clot if you meet certain criteria. The subacute phase of the stroke, you can give them antiplatelets like aspirin or clopidogrel, high intensity statin, and blood pressure control. Now, if the stroke happened from a source, a cardioembolic source, that means that there was a thrombus in the heart that went into the brain, for example, from atrial fibrillation, you can give them anticoagulants. This is the part that confuses students. If the stroke is from a low pressure circuit like the left atrium, then you can give them an anticoagulant. If the stroke is a thrombotic stroke, we give them antiplatelets. Okay, hope that makes sense to you guys. Lastly, if it's a hemorrhagic stroke, like an intraparenchymal bleed or subarachnoid hemorrhage, you give them, try to control the blood pressure to prevent more bleeding, and you give them a medication called nimodipine for subarachnoid hemorrhage, and that's used to prevent cerebral vasospasm. Next is treatment for DVT and PE. And again, DVT and PE is a low pressure circuit. So what are we gonna use? Are we gonna use anticoagulants or antiplatelets? Yes, anticoagulants. So if you have an acute DVT, you want to stop the propagation of the thrombus, so you can give them medications that kind of act quickly, so heparin, enoxaparin, or fondaparinux. If you have a PE that's very big, that's affecting the hemodynamics, you can give them alteplase. For chronic DVT or PE, you can give them any really of the anticoagulants. So warfarin, oral anti-10A inhibitors, dabigatran, Or if a patient is pregnant and can't take like any of these, you can give them enoxaparin or heparin. Sometimes you might need to prophylax patients for DVT. So patients that are immobile or have high risk of getting a DVT because of surgery or whatnot, you can give them enoxaparin or heparin or the oral anti-10A inhibitors. So that really concludes our discussion with the antiplatelets and the anticoagulants. I hope it made sense to you guys. Please go back and review it again. It's very, very important that you understand the concepts in this lecture. If you have any questions, please don't hesitate to email me or email Mike, and we'll be more than happy to answer you.